Okay. Hello. Um, Good morning, everyone. In fact, good morning, good afternoon, good evening, from wherever you're joining us. I'm Dr. Parva, your host for today. I hope I'm audible to everyone. Please send in some yes in the chat box if I'm audible to everyone. Okay, perfect. Good. Okay, so welcome to the webinar. Thank you so much for taking your time out and joining this webinar. I hope it will be very beneficial for you, and I hope that we will be able to answer your queries. So today we are going to talk about the PLAB-2 vitals, the PLAB-2 essentials, how to ace the exam, and also we are going to talk about how you're going to ace a good job after clearing the PLAB-2 exam. Like always. Okay, we'll wait for everyone to join for 1 minute, and we have some, reminder for everyone. Please keep your cameras and microphones off during the webinar while the speaker is speaking. If you have any questions, please throw them in the chat box. We will try to answer each and every question by the end of the session. Okay. So. And during the session, if I'm not audible or if you have any issues, and if in case I don't read the chat box, please feel free to unmute your mic and let me know. Okay. Okay, so we have a good strength. Let's start the session. Um, Today's agenda, what we are going to talk about today in this webinar. First of all, there will be a brief introduction. We would tell you our approach to tackle the counseling stations, and then we'll be talking about depressed patient. Of course, not a depressed patient or a station. Depressed. There is not a depressed station. Always there is, like we talked in our previous webinars. There can be any station. A patient can come with any problem, and then he or she might be depressed because of it. Okay, so how to tackle with that patient, how to make him or her speak, how to develop a good IPS. We'll talk about that. And the most interesting part of today's webinar is the research and CV building. So basically, you are going to talk about how you are going to make a very nice CV and how to improve your CV once you are, clear the exam and you are here in UK ready for your first job in NHS. Research. We are going to talk about research. Why? Because research is very important. To be honest, anywhere in the world, you go anywhere in the world for a job, research is a very essential thing. It just improves your CV 100 folds. So we are going to give you some pointers on how to how you can improve your CV and how you can do the research and add it into your CV. And then at the end, we'll have a panel discussion, a live question answer session. We have the speakers, Dr. Kokab Nasir with us, and we have Dr. Daniel Shabir, and I myself, I'm Dr. Farwa Aslam. We are your facilitators for today. So let's start. I'm going to start with the counseling stations. 1 minute. Okay, so I'm starting with the counseling stations in PLAB-2. Okay, so counseling station. First of all, how do you know when you are in the exam and you enter the cubicle? How do you know it's a counseling station? Any ideas? How do you differentiate a medicine station and a counseling station? What's the major key difference when you read the scenario and you know, okay, now this patient is here for counseling? Any ideas? Anyone has any idea? Just type in the chat box. Okay. Well, let me tell you what's the difference, how you differentiate between a counseling station and a medicine station in a address concerns. Okay, yeah, that is how you start the counseling station. Right now I'm talking how you differentiate. How you differentiate is when you read the scenario. If there's a patient who comes with XYZ symptoms, okay, now he's here, and you have to talk to the patient, you just have the symptoms, okay? You don't have the diagnosis. So it is a medicine station, medicine, peds, whatever. Now you have to make the diagnosis. In counseling station, there is always a diagnosis. The patient already has a diagnosis, he or she already has a condition, and now he or she has a concern about that particular condition, and you have to counsel that patient accordingly. Okay, exactly. Very wonderful. This Sharmi, diagnosis is already there in the question, so perfect. So in counseling station, the first thing is there's always a diagnosis given. So when there's a diagnosis given, you have to, this is a counseling station and you have to counsel the patient. So now, how are you going to start the counseling station? Now, my next question, somebody already gave the answer that we'll start with by addressing the concern. Very right. So what about the concern? I'm giving you, is there any volunteer who can talk to me? Anyone? That doesn't matter if you know a counseling station or not. Doesn't matter. Counseling station is the most important station, I believe, in PLAB-2, and people think it's very tricky. It's very it's a little difficult, and they are always nervous how to tackle with such a scenario. But trust me, after the approach I'm going to give you, it is going to be like an easy cake for you. So, and doesn't matter if you don't know the counseling stations yet. I just need a starter. So anyone, if anyone can volunteer on how you are going to talk to the patient about a counseling station. Come on, anyone from the audience. Build a report. Okay, fine, right. Okay, so let me just give you an example for a counseling station. Okay, for example, there is a patient who was diagnosed with epilepsy like 5 years ago. Okay, and he was given some medication, and now 2 days back or 1 day back, he had an episode of fit. So he's here with a concern, or he's here with a concern that obviously why he got that fit. Now he talked to the patient. So obviously you'll start with rapid building. Hello, my name is this, your name, age, everything. After that, you'll be definitely asking, how can I help you? And the patient will say, okay, doctor, I had a fit and I'm concerned about it. So what you'll do, the first thing, you will explore that concern. So now how you're going to explore that concern? The first thing, the most important thing, trust me, before even exploring the concern is that actually fails you, that is going to fail, that is going you to fail is, when you read the scenario and you see that, okay, the patient had epilepsy 5 years ago, or the patient was diabetic, was diagnosed with diabetes 10 years ago, and now he had a episode of fall. So the first thing that comes to your mind is, okay, it's a fit, it's epilepsy, or in the other scenario, it's a hypoglycemic episode. So, all the risk factors, they come to your mind and you are like, okay, I'm going to go in and I'm going to counsel the patient about all the risk factors and advise him about all the, things related to epilepsy or diabetes or whatever other condition the patient has. This is going to fail you. Okay. This is what, I mean, this is how it shows that you are scripted. So the first thing that you're going to do is, if the patient comes with a history of fall, for example, it was a history of fall with a fit or whatever, the first thing that you should think about is, okay, fall, the DDs of fall, the differential diagnosis of fall. Okay, forget about diabetes, forget about epilepsy. So the first thing is, you are going to explore that incident that happened, that fall, that fit or whatever generally. Okay, don't focus or don't limit yourself to that particular diagnosis or the particular thing in the scenario, because obviously you have to show that you are not scripted. Okay, you are here for the patient, you care for the patient, and you're being a safe doctor. So you are going to talk about everything. It is possible that he was diagnosed with diabetes 10 years ago, he's on insulin, but that episode of fall is and there might be some other condition diagnosed in last 10 years, or maybe he's taking some medication that is interacting with the insulin or the diabetic medicine that he's taking. Anything is possible. Okay, or maybe he's epileptic and he had a fit or a fall because he's stressed out about something, and something triggered and something happened, he had a very high fever and he had a fit. Anything could happen. So don't limit yourself to the scenario, to the diagnosis. Start with a very open approach, open-minded, enter the station open-mindedly and ask the patient, okay, what happened? He says, okay, I had a fall, I had a fit. So, okay, so what happened? Can you explain? So the patient will tell you whatever happened. Okay, I'm going to give you 3 questions on how you're going to explore the concern. But again, like I always say, these questions, the approach that I give you, it's only there. It's just like put it on the sidelines. First, listen to the patient. Give him the time and the space to talk. If you think after he's finished talking, okay, something is missing, then okay, pick questions from the approach that I'm going to give you and then ask that patient. Okay, but first let the patient speak. Sometimes the patient literally in one line he will tell you everything. So give him the lead, give him the time to tell you everything. Okay, now he's done. You still think something is missing, you can ask a particular question. Okay. Okay, this really Shalika, very right. Rapport, sympathy, empathy, very nice. Okay, so how you're going to explore the concern? That's what we are talking. The patient had a fit. Now we are going to explore that concern. There should be 3 things in that concern. The first thing is before. What happened before the fall, the fit, whatever happened. Okay, what happened before the fit? What were you doing at the time the fit happened? For example, he told you that okay, I was maybe I was preparing for the exam, or maybe I was at a party and I was drinking with my friends. Drinking alcohol is a trigger for fits, so it could be that. So here he gave you the risk factor. So always ask what you were doing or what happened before the incident. Okay, the second thing is what happened during that incident. Okay, so now the fit happened. What happened during the fit? He'll tell you, I lost my consciousness, there was a vomiting, a froth from my mouth, or I passed a urine, tongue bite, whatever happened during the incident. And the third thing is after. What happened afterward? He gained the consciousness, someone brought him to the hospital, he was given some treatment, sent back to home, whatever happened. So explore the concern by asking these 3 things: what happened before, what happened during the incident, and what happened after the incident. But like I'm saying, first ask the patient, okay, tell me more about it, and he will tell you everything about that incident A to Z if you give him the space and time. Okay, now he's done and you still think, okay, he missed what happened afterwards. So you can ask, okay, so you were telling me that this happened. What happened afterwards? Okay, now he will tell you, okay, I was brought to the hospital, I was given this treatment, I went home, but now I'm concerned that why I had that fit at the first place. Okay, so the next thing, what you explore the concern. Okay, so the next thing you're going to do is you're going to do the data gathering, history taking. And like I always say, history taking is very important. Always history taking or data gathering, whatever you want to call it, it's very important in each and every station. Trust me, even when you go on the GMC website, there is the plan is that there are 4 marks for history, 4 marks for management, and 4 marks for IPS. And there's no separate patron for constant stations or Breaking Bad News or Simmons or nothing. This is a universal criteria, and they are going to judge you for a history, for management, and for IPS in all the stations, no matter what sort of station that is. Okay, so even in the counseling station, you have to take the history, a very brief history. Now, what are the advantages of the history? I'm not asking you to take history only for those 4 marks. No, I'm asking you to take the history for some other reasons as well. Any idea why we are taking the history? How it is going to help you counsel the patient? Any ideas? Come on, please write in the chat box. Any idea why we are going to take the history in a counseling station? I mean, I can simply go and counsel the patient. I know, okay, he's here for the episode of FIT, and I can tell him, okay, these are the risk factors. You might have gotten the FIT because of this, and I can give him some advice. So why I'm taking the history? Any ideas, please, from the audience? Why do you take the history? Why history is important in a counseling station, other than, of course, the 4 marks that you want to get? Anyone, please, come on. No guesses? Even if you're wrong. To help in management, to have idea about the patient condition. Perfect, wonderful. So you guys already have a very good idea to enable the answer questions that would be asked. Very, very nice. Okay, thank you so much, and wonderful. Almost everyone answered correctly. Okay, so why are we taking the history? Drug interactions. Okay, good. Previous history, wonderful. Okay, everyone is correct. So basically, why we are taking the history here is, For example, okay, it's epilepsy, and now you have to consult the patient about a fit and a fit episode about epilepsy. There are 10 risk factors. I'm just hypothetically talking about this. There are 10 risk factors that you have to talk about. You know, okay, you read in some notes, you read somewhere, these are the 10 risk factors related to epilepsy. Okay, 1, 2, 3, 4, 5, 6, 7, and 9. And you go in there, you start talking about all of those 10 risk factors. 1, 2, 3, 4, 5. Now you're at 5, and they just ring the bell. And then you're like, okay, now I'm done with the station. But the patient is not satisfied. Why? Because you didn't address his concerns. And how do you know his concerns? By getting the data, by taking the history. History helps you in two things mainly. First of all is to know the risk factors. And second thing, it is going to help you in the management. Because without taking the history, how do you know this patient, she or he had a particular fit? Why? They are like 10 different reasons. There could be 10 different reasons. Again, like I said, there might be some other condition he was diagnosed with and you don't know about it. He might be taking some medication and it's a side effect. You don't know about it. He might be like, he told you, okay, I was drinking alcohol, or maybe he's doing some other activity that you don't know about. And how will you know about it? By taking the history. And then when you know the risk factors, then management is easy peasy. You can easily talk about, out of those 10 things, you can just focus on those 2 or 3. Trust me, you don't need to talk about those 10 things. Always, your management should be tailor-made according to the patient. And how do you know that? By taking history, brief history, just in 2 minutes. Okay, now the patient is he's diagnosed with epilepsy. So okay, ask him first, take consent. Okay, so if you don't mind, we have a little chat about your medical condition, so I would be able to address your concern or answer your queries in a better way, however you want to phrase it. Okay, I'm not going to give you any script. However you want to phrase it in your own language. Okay, so can we talk about it? The patient says, okay, fine. So okay, so when were you diagnosed with epilepsy? Now he's going to tell you that I was diagnosed 10 years ago. Okay, so what investigations were done? Okay, he'll tell you what medication was given to you. Now, if he is on some medication, he'll let you know, okay, I was given this, or either he remembers the name or he doesn't, he'll let you know. If he tells you about the medication, the first thing that you're going to do is, okay, are you taking that medication regularly? You know, it's a very big risk factor. He might not be compliant. He might not be taking the medication, and that's why he's having the fit. And here the patient tells you, okay, no, I stopped taking it like 6 months ago because I was not having any fit episodes anymore. So you're like, okay, now you got one risk factor. Okay, then move on. A brief history about the medical condition. Okay, now you ask P2 P3 maftosa. Simple. The pattern you all know. P2 P3 maftosa. In P2, what do you ask? P2, other medical conditions. Always ask other medical conditions, so you know, okay, other than epilepsy, are you diagnosed with any other medical condition? Okay, are you on any other medication other than whatever medication he told you about? Okay, then okay, DESA, he already told you that he was drinking. Otherwise, you can ask, do you drink or do you smoke? And then in maftosa, not always, trust me, this P2 P3 maftosa, these are the things you have to choose according to the station, what you want to ask, what you need to ask, and what you need to skip. Okay, in MFTOS, say you simply here you can ask about the medication. That's it. You don't need to ask about a lot of maybe travel history and social history stuff, depending on the station. Okay, you can change you can pick M, you can pick O, you can pick F, whatever you want to pick out of that maftosa or DESA. You can just pick those things. Okay, according to the time, the scenario, you have to manage the time, of course. Okay, so we took the history. In history, the first thing, we divide the history into 3 things. The past. In the past, we did the P2 P3 maftosa. Okay, any other medical condition, any other medication he's taking, any other he's drinking or smoking or whatever. Then there are 3 parts. Then the second is present. Ask him, are you okay right now? Are you feeling all right? Do you have any symptom right now? In pain? Any palpitations, any headache, anything, just to ask him, okay, everything right now, is it that all right? He came with you with a concern that I had a fit 2 days ago, so just to be safe, okay, is everything okay right now? So that's present. And now again, I'm dividing the data gathering into 3 parts: the past, present, and the future. Future is of course the management. Okay, so what you're going to do in the management now, for the first thing, I'm just repeating the whole thing. You asked about the concern, you address that concern, you explore that concern, basically, sorry, you explore that concern by asking before, during, and after. Okay. Then you did the data gathering by asking the past and the present. In past, you asked about the a very brief history of their medical condition. Then you asked about P2P theme of TOSA. Then in the present, anything presently, any concern other than this. And now we go to management. So management is the most important part here in counseling. So basically, you have to counsel the patient. Right now, everything that you did up till here, that was for your own benefit. You needed to gather all that information in order to manage the patient in a nicer way, in a brief manner. Okay. So in management, there is a very nice mnemonic for management. I'll give you. It's ARMMS. It's arms. Okay. So what does ARM stands for, and how you're going to counsel this patient now? So the first thing, A stands for advice. You're here to counsel the patient. You're going to give some advice. Okay, how you're going to give the advice? R is for the risk factors. These are interlinked. Now you have the risk factors, and you're going to advise the patient about those risk factors. And from the history you gathered, he's not taking he was drinking. Number one. Number two, he was not taking the medication on time. Okay. And we had anything else? No. Okay, we had these two risk factors right for now. There could be others as well. Okay, he couldn't tell you, okay, I have some exams, I'm very stressed about it. So that is also a risk factor. Anyways, whatever risk factors you gather from the history, now you're going to address those risk factors. You're going to advise the patient about those risk factors. Okay, okay, first of all, he was non-compliant. So tell him that, if you're diagnosed with epilepsy, you have to take the medication unless you're free of any epileptic episodes for at least 2 years. Okay. So, you stopped taking the medicine 6 months ago. So that might be a trigger for your fit. Then again, drinking is also a risk factor. So whatever risk factors you get it from the history, you are going to address those risk factors and advise him about those particular risk factors. M is for medication and investigations. If you think that you need to do some other investigations at the present moment, you will talk about those. Otherwise, you can tell him that I'll talk to the senior and we will review your medication accordingly. Okay. Third is multidisciplinary team. Multidisciplinary team is usually right now the patient is here for counseling. So you just counsel the patient, give him some advice, and you'll tell him to come for a follow-up if follow this advice for some time. And if you have another episode, then come to us. He followed the advice, he still had an episode, then he'll come to you, and then you can tell him that we will refer you to a specialist. But for now, we are giving you some advice. We are going to manage you these basic steps, so 1, 2, 3. Follow those steps. If you are not, you're still not, it doesn't work for you, then come back to us and we will refer you to a specialist. And the last is safety netting. Safety netting about, again, about all the risk factors that you have in future. If you have any fit, what you have to do, the most important thing here is in safety netting for it, like I was talking about the epilepsy, don't drive. Before telling him don't drive, ask him, do you drive? Okay, if he says yes, then tell him, okay, so I would advise you not to drive for until you are treated for epilepsy, and kindly inform the DVA a little then. Don't tell him directly, okay, and also please in safety netting, do not drive. Okay, do not drive. He'll say you, okay, doctor, I don't drive, or I already don't drive. So why you are telling me this? So first ask him, do you drive? Okay, he's saying, or do you drive, or what other activities do you do? Okay, do you swim and stuff like that? If he's swimming, he's driving, then you can tell him, okay, you need to be careful about those things, and then you can safety net the patient about this thing. Again, in management, the most important thing during this counseling and giving this management, the most important thing is understanding of the patient. Understanding. Okay, don't just keep speaking, talking about everything that you gathered. Okay, now you gathered the information correct, you are going to advise the patient, counsel the patient, but at every step ask the patient, do you understand? Are you following me? Am I going too fast? Do you want me to repeat it? Check his understanding. Keep checking his understanding, that okay, do you understand that? Okay, is it okay with you? Keep if you are giving him some investigations, okay, I think we should get you tested for this. Is that okay with you? We are going to test you for this. Why we are going to test you for this? And then are you okay with it? So 2 things, why and consent. what you're going to do, why you're going to do, and are you okay with it? Keep asking this. Your purpose in this in the examination is not to showcase your knowledge that, okay, I know a lot, I know all the stuff about epilepsy, and I'm going to tell the patient, counsel the patient about epilepsy. No, your goal is to make the patient understand. Even trust me, even you are able to make him understand just one point, one thing in your management, and he's satisfied and he understands you, trust me, you have aced it. You are done with the management. Okay, you have done it in a good manner. Doesn't matter if you missed, okay, the time is up and you missed the other four things, but trust me, if you are able to make the patient understand only one point on the management, okay, that do you understand, and he's happy and satisfied with your management, okay, yeah, I get it, you did it, you did it well. Okay, then that's it. So we are done with the counseling stations. Do I need to repeat anything? Everyone is clear about the counseling station, right? Kindly throw me some yes, so I know that, okay, you guys are okay. Perfect. Okay, so now I'm going to I would like to request Dr. Fokab Nasir, and she'll be here to talk about some stations with some depressed patients. Okay.
Hello, everyone. Good day. Thank you, Dr. Farwa. Welcome to the webinar, all participants. So we are going to discuss the challenges behind depressed stations, depressed patient station. Depression cases are comparatively more challenging. Why? There are many reasons. If we go behind the definition of depression, that is a mood disorder that affects all areas of life. However, the good thing is, with appropriate right treatment and support, most of people with depression come out of it. They make full recovery. So it affects every area. There are many psychological symptoms, as we know. There are many physical symptoms. So whatever symptoms come across, depression can present with that. We cannot label any case with depression simply that patient will come and tell you that I'm feeling low, or I'm sad, or I'm hopeless. This is typical presentation. If some candidate gets this, it's really brilliant. But usually in PLAB-2, GMC presents cases of depression in multiple ways. The challenging aspect is, number one, these cases are quite long in terms of history taking, in terms of management, and in terms of IPS, because sometimes patients are not very quick to understand and very quick to respond. So there is an issue with time management. This can be best tackled with more practice and an appropriate approach. There are many depression cases, like roughly 7 to 8 scenarios, and they repeat these scenarios every day or every other day. So this area is quite common exam scenario. And there are multiple presentations. Depression case patients, the cases of depression they present, these can be with any physical symptom even. For example, patient may present with insomnia. And when we explore insomnia and we reach to the evaluation of mood of the patient, and then we come to know that, okay, the patient was having depression. All the same, patient may present with low mood, drug abuse, and sometimes these patients present with relationship problems. Sometimes there is bereavement in the background. And then there is postnatal depression. It is another entity. So because of all these reasons, depression becomes a challenging area. While preparing depression, keep in mind all the symptoms which can be presented as depression. Secondly, depression can present as mild, moderate, severe, and with suicidal intention. So we should be ready to deal with every aspect. If the patient presents with mild symptom, then how shall we diagnose and how should we manage that patient? If the patient is presenting with moderate depression, what will be the management? What will be the areas to focus upon? Which patients are supposed to be referred to specialist mental health team? Which patients will be treated in GP surgery? So there should be an idea, a clear sketch in your mind that what are we going to do with which particular patient. So if we discuss certain areas, like how GMC presents the scenario and how can we pick up those things. But before that, it's important to know about that how can we pick nonverbal cues. Usually in these patients response is not warm. They might be friendly, they might be okay, but they are usually a bit slow to respond or a bit dull. Sometimes they keep on looking on the floor, they don't have good eye contact, sometimes they don't smile back to you, and sometimes they apparently or visibly look unhappy or sad. In some instances, patient may be tearful. So remember to pick all these non-verbal cues. This is great help because the simulators try to look like real patients and they try to present a patient like depression. So a depressed patient, we should keep in mind that how can he be looking like, and we should focusing upon that thing. So going back to our PLAB-2 scenarios related to depression and what kind of ways the depression can be presented. There is always something in as hidden agenda. Usually, when we see question outside the cubicle, that can be in certain ways. For example, the straightaway case can be a patient is presenting with low mood, which is usually less common. Then there can be a patient is experiencing some new symptoms which were not in his life. For example, any weight changes, sometimes weight gain, sometimes low weight loss, and insomnia, newly onset insomnia. Then there can be a background trigger. For example, joblessness or leaving the job or got fired from the job, some chronic illness, some relationship problems, either divorce or like death of some near and dear one, some failure in academic career, and never forget personal history of psychological issues or depression and family history of mental health issues. Drugs and alcohol can be in the background. So keeping all these things in mind, we can know how challenging depression cases can be in how many ways they can present. So when you see a case scenario and if you pick up that it can be depression or not, the best way is there is a certain areas where we must explore mood. Earliest we assess the mood and impact of symptoms on patient's life. In which areas? On job, sleep, routine, relationships, and mood. If anything is affected, all these things, patient might go into depression. And it is the best idea, as you pick that this case might be of depression, then immediately explore his mood with screening questions. And what are those screening questions? Everyone would be knowing that loss of interest during past 2 weeks, most of the days, and persistent sadness, lack of interest and persistent sadness. And then there are certain criteria of differentiating mild, moderate, and severe depression. In PLAB-2 scenarios, we are having cases with insomnia, then with tiredness, Then there's a case with postnatal depression. There's a patient who has tried certain things for moderate depression but is not recovering. So if we are aware of all these scenarios in our mind, that depression patient can present in any way, these are the already presented scenarios. What are unrevealed? For example, in the long run, we can have any patient of domestic violence with depression or with a chronic illness, for example, rheumatoid arthritis or osteoarthritis or coronary artery disease. These patients can very much present with depression, and GMC can bring up such cases with new turns and twists. So when we come to any case of depression, if we know very well, if we don't know, we can go with symptom, whatever has been presented to us. For example, they can present us test results for tiredness. The patient was feeling tired for a week or for a year or so, and a week ago she got tests done and everything is fine. There is no organic reason for her tiredness. And after taking history of tiredness, when we reach to her mood, she may give some clues that her mood is quite low, maybe 6, 5. And when it comes below 7, it is significant for us to take some action. Another thing which is challenging, sometimes, actually most of the time, patient doesn't know that they are experiencing or going through depression. They come for their other symptoms, and then physician comes to know that no, the background actual reason is depression, and that is the apparent symptom is only trigger. For example, there can be insomnia because of depression. There can be tiredness because of that depression. If we go behind the symptoms of depression, then there is a long list of physical and psychological symptoms. So we should keep all these symptoms in mind and need to assess our patient quickly on the basis of these things. The best thing is when you assess mood of the patient and think that this can be a case of depression, then go for rest of all symptoms very quickly, including sleep, appetite, any weight changes, tiredness, any lack of concentration, energy level of the patient, any feeling of guilt, hopelessness, worthlessness. And on this basis, you can assess as depression is a clinical diagnosis, and we need to do certain tests just to rule out other possibilities. So after taking this good history, then we must need to rule out other differential diagnoses, which are usually hypothyroidism, psychosis, maybe post-traumatic stress disorder. There's a long list of differential diagnosis for depression, but main thing is which is relating to our patient at that time. And in general, if we rule out 2 to 3 other conditions as differential diagnosis, these suffice usually. For psychosis, it's important to rule out hallucinations. For hypothyroidism, weight change can be asked. We can ask about skin changes, about menstrual cycle or anything. So after ruling out psychosis, hypothyroidism, if needed, post-traumatic stress disorder, then we should have enough data in short time so that we can do rest of history taking. We cannot miss any lifestyle question in depression, unfortunately, because everything has an impact on depression. And these things are needed to be addressed in the management. And sometimes we find triggers there in psychosocial aspects. So psychosocial history is more important in cases of depression. Is the patient having some relationship issues? Is the patient having some supportive network around him, support by friends, support by family, who can take care of him, who can nurture him in that difficult time? And is he having any problems with finances? Is he having anything any kind of support at home? Do they need any support at home, at workplace? So anything related to psychosocial support is much more significant in all psychiatric cases and in particular depression cases. And when we come to psychosocial support, we can never miss the idea to explore suicidal intention of the patient or harming to others. It's always important. Is there anyone dependent living with the patient? How is the relationship? And does the patient feel safe about them as well? Now, coming towards suicidal ideation, always explore suicide in third person. Don't ask directly. The better ways to explore is, for example, well, Paul, you are not feeling good, or you are feeling so low these days. And sometimes people going through such conditions may think of harming themselves. By any chance, is that the case with you? Like, it should not be judgmental. It should not be offensive for the patient. He should feel the doctor on their side. He should have the feeling that doctor is concerned about me, not going to be judgmental for my decision or thinking. So always remember to explore suicidal ideation and harm to others. Always keep in mind to safeguard dependence in case of a patient who is depressed, and especially if he's in severe depression. In a clinic or in an exam scenario, when we are having a narrow 8 minutes window, how can we judge or assess that patient is going to be mild or moderate or severely depressed? Any patient, as some people say that we can count symptoms, positive symptoms, but it gives a bit more difficult scenario, because if we go on counting the symptoms, how shall we connect with the patient in that short time? In NHS, we can find that any depression which is not affecting patient's life much, he is having mood problems, he's not enjoying life much, he has lack of interest in things he used to have earlier, but he is continuing with job, he's continuing with relationships, but having certain symptoms of depression, then we will diagnose him as mild depression. And a mild case of depression will be treated with lifestyle modification, and if needed, talking therapy. And talking therapy can be of certain types. It can be CBT, counseling, it can be psychodynamic psychotherapy or interpersonal therapy. We don't need to tell all types of therapy to the patient at once. We just need to know what the patient needs. For example, a patient coming from a background of relationship problems might be needing an interpersonal therapy. A patient having problems within the couple, they might be needing couple therapy. A patient who needs to change his mindset or the way he looks at life, they may need to go for cognitive behavioral therapy, CBT. But in general terms, for patient, we can use the term talking therapy. And if they explore further, we can tell about that. Generally, we don't need to tell how many sessions, how many sessions and how much duration of those sessions and for how long. But we can tell the patient that your counselor or your interpersonal therapist or your psychodynamic therapist, they can suggest after talking to you that how many sessions and for how long duration you need it. Generally, we are not supposed to give details of all of our management plans. We should have idea in our mind. We should have knowledge, but we don't need to give that knowledge in a bulk to our patient. Give that knowledge in chunks and then check. Does the patient understand that chunk of information? And is he agreeing with that or not? And is he happy to go with that or not? And then proceed to the next step. So for a patient with mild depression, it's important to tell about talking therapy it's whether it is mild depression, but we will mention about crisis card. It is vital for depression cases. Whether patient mentions suicidal ideation or not, but we need to mention this will be his safety netting. We cannot leave the patient unaware of that crisis card or NHS urgent mental health helplines, or even for a patient of mild depression, we can offer, if he's not willing for talking therapy, we can offer free listening services at Smartians. And then leaflet will be given, and these patients are followed up at GP surgery, mild depression. And if a patient is having depression, many symptoms of depression, and this depression is affecting their life very badly, like either their relationships are affected to the points of no return, or they need to suffer at job, or their jobs are at risk, or they are unable to cope with their routine life or routine things, or they need to put extra effort to maintain their routine, then in that case, we can diagnose the patient as moderate depression. These cases are also treated in GP surgeries, and we will go for pharmacological and non-pharmacological options. We have discussed earlier non-pharmacological options. First of all, there is psychosocial support. Who is in the family? Who is in the friends? Can they help him? If not, support groups where people experiencing symptoms or conditions like them can share their ideas. And these are the best platforms for a patient to learn and to know how to live with that condition. I hope I'm clear so far. So for a patient with moderate depression, we will address all those things which are considered in mild depression, like lifestyle modification, like psychosocial support groups, talking therapy. All these are non-pharmacological options. And we need to discuss about pharmacological options. Again, we will not give all the knowledge at the same time. We will just give an idea, and patient will bring up their own concerns. Some patients are concerned about side effects. Some patients are concerned about long duration of use of that medication. Some patients have the concern of compliance. So according to, listen to the patient, what do they say, and then tell them the details. Let them ask you. In the management, it's good to involve patient. Either he agrees with you or he asks you something. And when they ask something, it is good for you because they bring you to the track where the examiner or where the examination wants you to go. So never miss these clues and cues from the patients. And pharmacological options, this is just text material you all can read. This is SSRIs, tricyclic antidepressants, monoamine oxidase inhibitors. What do we need to know? Side effects, withdrawal symptoms, how does the medication work? What is safety netting here? Not to stop that medication. Safety netting particular to SSRIs or any medication, that not to stop abruptly without consulting their physician. Compliance is more important. So all these things you can read and you will frame it according to your patient's question. And never ever forget about crisis card. And in moderate to severe depression, we need to mention about DVLA. Reason, a depressed patient, he is lacking concentration. Sometimes they are not having good judgment, and they can be a risk to themselves or to other road users. And if during driving they get the idea of suicide, then it can be harmful for them. So whenever there's a patient with moderate to severe depression, always ask them to inform DVLA, and then they can go further. I hope I'm clear. And then comes severe depression. Usually this is the case when in either CBT or both CBT and pharmacological treatment, both are failed. Patient is not recovering or improving. In that case, we are supposed to refer patient to specialist mental health team. Who are the members of specialist mental health team? Though we don't need to tell to the patient, but we should be aware of it, that it consists of psychologists, psychiatrists, specialist nurses, and occupational therapists. So, and sometimes counselors are also there. So these, when the patient is with severe depression, then we need to, will you please mute yourself? Okay. I'm sorry. It was like when the patient comes with severe depression and he has not responded to CBT or medication, we can refer them to specialist mental health team. There are certain other cases when we need to refer the patient to mental health teams or hospital, psychiatry departments. These are postnatal depression, a patient who is not responding to pharmacological treatment, and any patient who has suicidal risk. We need to safeguard that patient, as well as we need to refer that patient to specialist mental health team. And postnatal depression will also be referred to specialist mental health team. However, rest of the patients with depression initially present to GP surgeries. That is why there's a great load on GP surgeries regarding depression. Now, management of the situation of the patient. This is the most important part of any case, that please don't treat the patient's condition only. Try to manage their situation. If the cause of depression is relationship, then they need to work upon that area. Also, if the cause of depression is bereavement, they need to work upon that. And we will help them out in this way. And when the patient, we don't know the cause of depression, but we are seeing that our patient is experiencing the effects of depression, then we need to explore the cause. So whatever is the situation, if there are financial issues, we can connect them to social services. If there are some dependents at home, for example, a mother, a single parent who is depressed and she is having a child at home, then we can take help from social services in that regard. If the patient is depressed and they are unable to carry themselves, they are unable to cope with daily living, then we can offer help in that regard as well. So it is the situation of the patient which will be handled by us. Now coming towards a general sketch of our patient. Whatever symptom patient is presenting with, that is that can be any of insomnia, tiredness, weight loss, feeling unwell, any vague symptom. We must need to assess patient's mood. How is the patient coping these days? How is the patient feeling these days? Moving ahead, after exploring their history of presenting complaint and all associated symptoms, we need to assess their mood. And if we find any risk of depression, we will go through the history of depression quickly. Meanwhile, assessing the patient for other differential diagnosis of depression. Going through patient's past medical history related to mental health conditions, patient's family history related to mental health conditions, any medications in their use, any exploring their alcohol, recreational drugs. And again, it's good to ask about recreational drugs in third person as well. Going through all these things, we will lead to patient's psychosocial history. In psychosocial history, we need to assess the patient support system, evaluate it, spend some time here because this will give you many clues. And pick up things. If patient is using alcohol to calm himself, or using recreational drugs, or smoking, or patient is keeping himself alone, or patient is not involving in any hobby, address all these things in the management portion. And always connect your data with the management. For example, if you want to say about exercise that is vital for patients of depression, that is, okay, Paul, as you told, you don't get time, you don't feel like exercising, you don't get time to exercise. But I must tell that your feelings will get better with exercise, because exercise is has proven beneficial effects for depression. Will you give it a try? Like, connect that thing, that why that, or it's good to leave, it is good to cut down on alcohol, because it is adding up to your depression. What do you think about it? Tell the patient that the factor in their life, you think that it is not good for their health, the current symptoms are worsening because of that, and then connect it with the management that if you cut it down, alcohol or smoking or recreational drug abuse, or add up healthy food, or add up exercise in your life, it will give you benefit in the long run. Okay. All the same, if the patient has presented with some other symptom, for example, patient says, I'm tired, always in the management, tell them that the basic cause or the root cause of your tiredness is your depression. When we are going to treat your depression, and this will ultimately recover your tiredness. I hope it's clear. And then always remember crisis card, and always remember talking therapy, what kind of talking therapy suits to that patient, and in cases where medications are needed. Now, Dr. Sara Allah is asking, so every patient will have follow-up in GP surgery? Yeah, when the patients are referred to specialist mental health team or hospitals, they get treatment there for certain time, and then they are referred back to sent back to their GP surgeries, and they are being followed up there. Okay, so now we are reaching to the end of this topic. Any questions? And one more point for suicidal ideation, if patient is not willing to go to hospital, because we cannot let the patient leave the hospital to go back home because he is in danger. We are supposed to safeguard that patient. In that case, we will involve crisis resolution and home team, HRCT, and they will take over the things at that point. So do you have any question regarding scenarios of depression? Okay. There are certain common mistakes which are repeated usually with in these cases. First of all, candidates often miss to pick up nonverbal cues. And these, then they can take the case of insomnia as simple insomnia, and they will miss the case. So try to pick up nonverbal cues, try to involve mood early in your history taking, especially in case of vague symptoms, which have many causes and which can have a depression as a cause. And any chronic condition, any drug dependence, always explore depression by asking about their mood. If it is a bit low, then go for screening questions for depression. And if these are positive, go with the history of depression and try to find that root cause. Secondly, patients don't, sometimes candidates don't involve psychosocial aspects. They don't involve family or friends or support groups, although it has a very good and positive impact on the patients in real lives as well. And sometimes the third main mistake is the case scenario in itself is long, history is long, and then there is a bit longer management. So if we try to tell each and everything, it will be really impossible to do in last 2 or 3 minutes in the part of management. It's best to do in 2 ways. Number one, you can give option to the patient that I have to talk about this, and this. For example, I have to talk about lifestyle modification and your medication as well as talking therapy. And there are certain things which are worried about, for example, crisis card and driving. So what would you like me to talk about first? By saying this sentence, you will save yourself that if the bell rings and you are talking about one thing and addressing patient's concerns in one way, examiner would know that you want to tell the patient everything, but you want to prioritize according to patient's choice. So don't go in every detail of everything, then you may run out of time. It's best way to be smart in these cases. Put many things in patient's code. For example, what do you want to talk about first? Of course, step by step, you can do rest of the things if you get more time. And if there is no time, at least you will be saved. And usually patients have 2 to 3 concerns with them. For example, they may be asking that what will be the effect of talking therapy, or what will be the role of lifestyle modification? Or sometimes patient may ask, how can I keep myself safe? And then you can tell them about crisis card. Crisis card, what is this? This is a contact number, which is 24/7, and patient can call them whenever they feel that they are unable to keep themselves or others safe. And if you don't remember this, even you can tell them to come to accident and emergency or call 999. All these informations are available on NHS. You can see it yourself. And now coming towards a few things about my exam experience. In my exam, I found it that simulators are usually helpful. And if we don't irritate them, they remain polite unless they are asked to be angry or they are asked to be impolite. I'll suggest pick up any kind of help if patient gives it to you. For example, in a case, I gathered data about smoking and everything, lifestyle modification during lifestyle questions. In the management, I talked about everything. And then patient said, doctor, I smoke. And then I picked the clue that he wants me to talk about smoking cessation and quitting smoking. This was not smoking cessation case. This was a general case, and it was not directly related to smoking, but the concept is even one cigarette is injurious to health. So I picked that cue. So I would suggest that listen to the patient, and if they give anything, just take it from their side to polish your case. Secondly, don't assume things and don't invent either. And if you assume something or just go with the flow and then you remember that you haven't asked that thing, please go back and specify or clarify that. For example, in a case, I was supposed to ask, I was taking sexual history, and I asked the patient that you need to bring your partner. And by that time, I remember that I didn't ask who the partner was, male or female. And I asked at that point, and he said, yeah, my partner is a male, like he was a gay. So if you think that you missed something, it could just modify your sentence and ask about that thing in a non-offensive or non-confused way. Be confident, but tell that you forgot it, or tell that you need to know this. And I'll suggest go with the flow of patient. If patient is not going deep in certain area and they are advised to do so, then don't probe much. For example, with one questions, when they say no, it means don't go in that area. For example, sometimes we asking about lifestyle questions, they just give quick responses about diet. Do you eat healthy generally? Yes. And then move forward. No need to explore that. Do you take healthy, balanced diet? Do you take vegetables and fruits in your food regularly? Just one question. If they say no, just leave that area, especially in lifestyle questions and things like past medical history or allergies, medications. They give yes or no answers, and these are quite helpful for us. If the answer is yes, then we need to explore. But when the answer or reply is no, then just go. Move forward. Okay. Any questions? Well, thank you so much. You have been very nice audience. And now I will hand over it to you, Dr. Daniel Shabir. Goodbye from my side.
Thank you, Dr. Kokab. That was a really nice presentation. So, everyone enjoying? Okay. So everyone, my name is Dr. Daniel. I hope you've listened to a few of my webinars before, and I don't think anyone can hear me. Can everyone hear me? Just reply with a guess in the chat box, please. Okay, great. So let's start with our own topic, which is going to be how to conduct a research. And then we're going to be discussing what to do with your CV, how to develop it, how to build it, just getting a general idea on what to present, in your CV. And then we're going to do just a little bit of those unsupervised stations, which may or may not come in the exam, but you need to be prepared for, whatever happens in the exam. Okay, so let's imagine you've all passed your PLAB-2. Yay. All of us are happy. Who wants to, make up a CV and do a research? It's boring, right? But it's necessary. I hate to tell you that, but it's very necessary. So how to conduct a research? What is a research? Basically, a research is something that you pick out from a field of topics. And what you do with it is you focus on it, you learn about it. And once you've learned about it, what you will do is, I did share the full screen. Okay, sorry, let me just share it again. Okay, I hope that's okay now. Okay, great. So a research is a topic that you pick up. A research is a topic that you might find on accident. It could also be a topic that you've planned beforehand. It could be a lot of things. What a research is not is, copy pasting. Sorry about that. Okay, so without further ado, let's find out how do you start and conduct a research, and then I will tell you about my own researches, how I performed them, how I came to, start my own research groups, and how I got them published. It's a very extensive process, honestly. So the picture you're now seeing in front of you is a very complex picture. Yeah, looks difficult. You do not want to read it. You do not want to understand it. That's okay. I will make you understand it. I will make it easy for you. So before we move on to this big hunk of information, I'll give you the general idea. Okay, so there are steps to, obviously, whenever you're doing something, there are going to be steps to perform it. Like for an exercise, you need to have the proper positioning. You need to have the proper equipment. Just like the exercises, just like everything you do in your normal life, a research also requires certain steps, certain prerequisites, some things that need to be done beforehand. No, my slides aren't moving, man. My slides are not moving. Yeah, that's intentional. Okay. So formulating a research problem, that is the step one. What you do is basically you find a problem. Okay. Now, once you found the problem, you're going to research all around it. For example, a cat is sitting on a floor. The cat is the problem. You're going to look around. Why is the cat sitting on the floor? Why is it not sitting anywhere else? What can I do to move the cat? Is the cat causing any problems? Is the cat making everyone happy? Is the cat making everyone sad? Is the cat sad? Is the cat happy? Just little questions. So the first part is formulating a research problem. How do you formulate a research problem? What it does. So you find a topic. Okay. For example, you find you're very interested in rheumatoid arthritis in children. So you go around your hospital, you look around for patients with juvenile rheumatoid arthritis. You ask some questions. Maybe there is a case with a rare presentation, or maybe you're going to look for an SLE patient, or maybe you're looking for something in the neurosurgery. Anywhere you really want to look, it's basically fine. Or maybe you do not want to look at specific patients or disease presentations. Maybe you want to look at how the patients are responding to treatment, right? And how the patients are finding the hospital environment. That's called patient satisfaction. You might have heard about it. A lot of research is being done on patient satisfaction. Certain topics like level of patient satisfaction in gynecology ward, level of patient satisfaction in the general surgery ward. Everything is a research topic if you look hard enough. So the first part in formulating a research problem is asking the right questions to yourself. You will ask questions from other people, but that comes at a later stage. So how do you do that? You find a topic. How do you find a topic? You look around. Once you've looked around, you found a topic, then you move on. Okay, so these are some boring slides. I could read them, but you can read them as well. So just read the slides. What it's basically telling you is everything that follows a research process. Okay, so what it does is it's basically a summarized form. How do you move around? How do you take one step after another? First, you find a topic, then you find everything you need to do about the topic. You find out how you're going to collect the information. Then you collect the information. Then you arrange it. All that stuff. It'll come, in a few minutes. I'll cover everything up. Don't worry about it. So the one thing people forget while conducting research or while thinking of performing a research is the financial aspects of it. Personally speaking, I have been bankrupt twice in my life while I was performing my researches, and that was because I did not have a supervisor. It's always good to have a supervisor. They can guide you, they can finance you. That's the most important part. So find a good supervisor. Maybe take permission from your hospital. If your hospital can fund it, that's amazing. If they cannot find a supervisor, if the supervisor can fund it, that's amazing as well. And the supervisor has the additional benefit of guiding you as well. Okay, but you're gonna have to put their name on top. So pros and cons, people. So you need to find a research topic that is, easy for you to do. Many of you might be conducting researches, might have already had certain researches under their belts. And those who do not have researches or, are looking for research projects, you need to realize something, that conducting a research, it's not a hobby. Okay, it's a full-time job. And you need to realize, okay, I'll get back to that, Kale. I'll get back to you. Okay, so let me just make it full screen again. Okay, I hope that's good. Okay, so you need to realize that it requires time, it requires effort, sometimes it may or may not require a lot of money, depending on your sample size. What's a sample size? It's the number of people you interview. It's the amount of data you collect. That's the sample size. Okay, so if the sample size is not in your city, or if you're covering multiple cities at the same time, you're gonna have to travel. You're gonna have to talk to those people. Sometimes those people might not be willing to talk to you. Sometimes, there might be certain other problems, whether, other people's schedule, your own schedule. So you need to keep that in mind. So for the beginners, I would say find an easier topic. Find something that is localized, and find something that is just easily available, that is easily approachable, does not cost a lot of money, like the patient satisfaction ones. So you can just go into your ward, any ward that you might or might not be working in inside your own hospital. So you formulate a questionnaire, you distribute that questionnaire amongst the patients, or you can interview the patients, fill up the questionnaires yourself. That's just the easy way. Okay, so you need to really, get the hang of it before you really dive in. And once you dive in, people, it's a very interesting, prospect, career-wise and as a, satisfaction-wise as well. So before research, as the slide states, it's important to identify gaps in your knowledge. You need to be knowledgeable about what you're researching on. You need to be knowledgeable about what you're going to do with your research, about what you're going to do with the data. If you have the data and you don't know what you're going to do with it, you don't know how to perform the analysis, you don't know how to, move around with it, that's just a waste of good data, isn't it? So step 2 would be conceptualizing a research design. So you find your topic, okay? I'm going to go with the patient satisfaction. So for example, I am trying to assess the level of patient satisfaction in the general surgery ward where I'm currently working, okay? Or in the COVID wards as I was previously working in. I actually did that, it was fun. So talking about the COVID ward. So personally, I have been working in intensive care COVID-19 for the past 2 years. I just got transferred to general surgery, which I love. So working in COVID-19 intensive care, it was a very brutal experience. You see a lot of casualties every day. You see a lot of sick people every day. So what I personally wanted to find out was how satisfied the patients are overall from the services that were being provided by the hospital or by the government. Okay, so for those of you who are watching from overseas, I am from Pakistan, and in Pakistan the hospitals are mostly government run. There are private hospitals as well, but they were not dealing with the COVID-19 pandemic. So working in a government run hospital, you should know how satisfied the people are with the services provided. So that's what we did. What we did was we asked every patient that came in, or if the patient could not talk as they were breathless, it was COVID-19 people. So we sometimes, if the patient could talk, we could talk to the patient. If the patient could not talk, they were maybe on CPAP or BiPAP or invasive ventilation. We would start talking to their attendants or relatives who were coming in to visit, or their caretakers who were there with them all the time. So what we did was we gathered a bunch of data. So now we had the data, we didn't know what to do with it. That was 2 years ago. So I'll continue the story as we move on along with the slides. So what we did was we found a topic, and now what we needed to do was establish a parameter. How do we collect the data? What is going to be the mechanism of collecting the data? Okay. So, and we also needed to know everything about COVID-19. We needed to know everything about the government policies, or what facilities was the government providing, what facilities were the overseas governments providing that our government did not provide. I'm saying government a lot, I'm sorry. So what is the main function of a research design? Designing a research is, it needs to be fun, or you get bored and you leave it midway. So what you need to do is you need to arrange everything beforehand. Even before you've started to collect the data, you need to arrange everything beforehand. How do you do that? You sit down and you think. You think about the topic of the research. Okay, that's my topic, level of patient satisfaction in COVID-19 wards. Good. Then you move down. How is this research going to be conducted? What is going to be the mechanism of conducting this research? Okay, what is the type of study is what exactly I'm trying to say. Is it going to be a cohort study? Is it going to be a mixed method study? Is it going to be a mixed method multi-phase study? Okay, I'm going to explain all those in a bit. I know, big words. So you need to design your study, okay? And then you need to design the boundaries and the limitation. How are you going to measure the quantitative aspects of that research? And how are you going to collect the qualitative aspects of your data? Then you develop a sampling strategy. Okay, it's basically data collection. Am I going to do it on a form? Am I going to interview the patients? Am I going to talk to their relatives? Okay, so all of these will be different categorizations. Do I want to divide them differently in different, do I want to put everything in a different category? Or do I want to just amalgamate everything at the end? Okay, now the fourth thing would be the frame of analysis. So what's a frame of analysis? How am I going to quantify the physical data that I have? Am I going to run it in some sort of an analytical software? Or am I just going to manually decode it? Okay, there are multiple ways. There are multiple ways to do everything. You need to know a few of them at least. And what would be the time frame of the research? Is it going to be a month long? Okay, there's a very interesting thing here. It can either be the time frame of the research or the population as well. So it can either be I'm going to collect data for 3 months and see how many samples I can collect, or it can be I am going to interview 200 patients. I don't care how long it takes. Okay, so it goes both ways. Then, so now we're talking about the research design. The research design is obviously crucial, okay, because ultimately it's the overall design that you have, it's the overall data that you gather, it's the overall principle that you follow that is going to allow you to shape your research in the way you like. Okay, so if you're going to collect 200, if you're going to collect data for 200 patients and you're not even going to quantify it, you're just going to say, okay, I collected data from 200 patients, this is a list of 200 patients, and this is the cumulative response. That's not a good way to present. A good way to present the data would be, okay, so I collected data from 200 patients. Okay, this many of the people were satisfied. This many of the people were not satisfied. Those who were not satisfied had these things to say. A number of people said these, and these things against the government or the facilities provided. And those in favor had their own reasons. Then you list the reasons and then you quantify the reasons. For example, 17% of the people said that the oxygen supply was very good. Okay, and then 30% of the people said that almost 95% of the medicines were locally available. And then a 17% of the people said that sometimes they had to go outside and buy their own medication because the hospital might run out of them or they might not be available in the hospital. Okay, so pros and cons. The second way that you present your data is going to be the best way. You have to make it easy. It's just like an exam. In any exam that we had, even during our med schools, I don't know about overseas, but in Pakistan, it was always the mission of every student to attempt the exam in such a way so as to, make the examiner, the paper checkers, not work at all. Okay, everything was laid out in front of them. The important points, they were supposed to be laid out so they wouldn't have to find it inside the paragraphs. Okay, so that's just the way our mindsets work. I don't know about the other, I don't know about other people. So what a faulty design does is it misleads, obviously, and it's just a waste of resources. Okay, you spend around $2,000 on collecting data, and at the end of it, you're gonna have nothing to show. So obviously, your supervisor is going to either sue you or, I don't know, debar you or something. So whenever you select a research design, it is just so important to just make sure that it is at least workable. It's at least possible. You cannot just stand up and one day and say, I'm going to interview 56,000 people in a span of 1 year. It is possible, but you're going to have to leave everything else. That's just not good. So select something that is manageable, that is, adjustable in your own timetable, that is less stressful financially on you. So yes, there are a multitude of study designs you need to be very well versed in. So there can be, there's a very nice design that I recently had the privilege of performing under Dr. Yasser Arafat. He's a PhD scholar from Bangladesh. He's a very renowned scholar. So he's a psychiatrist. So what we did was we developed this mixed method multi-phase study design. So it's a three-step process where what we dealt with was basically suicide. Okay, so suicidal ideation. So what we did was what we did was we collected data on the suicide patients in a specified region. So we covered from 2018 to 2022 in the local region. We collected all of the data of suicide attempters and suicide completers. That's what we call them. So many people, they try and commit suicide, and some of them are successful, some of them are not successful. So what we did was we took 100 people who were successful in committing suicide and passed away, and another 100 people who had failed attempts. So this was phase one. In phase two, we went to their homes. The people who survived and the people who died, we went to their homes. Those who survived, we talked to them as to why they were committing suicide and what were the reasons behind them. And we also talked to the relatives of the people who died, just generally inquiring about why they thought their loved ones they committed suicide. In step as a second part of step two, we also went to the emergency department doctors. We interviewed them on how many suicide cases they dealt with on a regular basis, what they thought were the problems, the common problems as to why people were committing suicide, and what could be done to avert it. Okay, and what could be done to avoid it, and is there anything that the government can do? Is there anything local people can do? Psychologically speaking, is there anything they can do to help the patients, and so on? And finally, in step three, we proposed a method to avoid, these suicide attempts. And we suggested a mobile application. It's called Wobot, WOEBOT. It's called a Wobot. And what it does is, if you're depressed, so you can log on to it, you can talk to a psychiatrist or a computer-generated software, and it'll help you sort out your life. So this is a very long research. It took us almost 2.5 years. Okay, so this is the sort of research you do when you're under a supervisor and you just have a know-how about how researchers work. Okay, so I don't know if most of the people understood that. I hope you did. I hope you respect me now. Okay, so whatever design you choose, you need to have a justification for it, because once you present your research to any journal, you need to mention, why am I choosing this study design? Okay, why not any other design? Why only denim? Why not any other kind of jeans? Okay, sorry. Okay, so you will need your reasons to as to why you implemented the research design. You will need every bit of detail that you can get. So moving on. So anything that becomes a means of collecting information for a study is basically a research tool. Anything like questionnaires, your interview guidelines, your performers, your interview tapes, everything is a research tool. Okay, so you start your research by you've done your method, you've done your study design, now you're designing a practical tool. Okay, now you're designing a research tool. How are you going to collect the data? You can do that by forms. You can do that via emails. You can do that by talking on the phone, getting phone recordings. You can go and interview the people and get their video recordings or audio recordings, whatever floats your boat, honestly. It's basically data collection. You just decide the way you're going to collect the data, and then you move on with it. So there's something called a field test. This is basically only for clinical purposes. So a field test is, for example, like a placebo effect. Okay, most of you must have heard of the placebo effect. Obviously, you're doctors, you've heard of it. So let's take the COVID vaccine, for example. So what the scientists did was they developed a COVID vaccine. They made two groups, a control group and another group. So the control group had the placebo and the other group received the vaccine. They did not know who received what and when. Okay, so basically this is talking about field testing is basically talking about the control trials. Okay, so then there is sample selection. So whenever you're writing an article, a research article, or a systemic review, or any form of literature, basically, you need to, there is actually a paragraph at the top of it for those of you who have not yet had, their researches. So there's a very summarized informative paragraph as to what this research is about, what type of study design was used, what the sample size was, how the sample was collected. It's basically a summarized form. Okay, so in that you also limit your sample size. Okay, for example, we only included males in the study who were 40 years of age, from 30 to 40 years of age males. So we did not select anyone who was below 30, and we did not select anyone who was above 50. Why did we do that? Because we wanted to keep it simple, because we wanted to observe how a particular disease affects this particular age group. So this is going to be a reason. Okay, so what you do with this is you basically, again, you're minimizing your cost, you're minimizing your time difference. You're basically making this efficient, as efficient as possible, while being clinically relevant. Okay, so sample size is a very nice thing to have. A large sample size is actually a very nice thing to have. So I also did this another COVID research, and what we did was, we were 9 people, and what we did was we collected data of patients who were tested positive for COVID-19 from 19 different cities. Okay, so what we did was we basically took every kind of data we could gather randomly. That really backfired on us because we didn't know what to do with the data once we had it all. Okay, so basically for a year, we had around 56,000 people whose information we had all along, and we did not know how to rearrange it, and we did not know how to work on it, and we didn't know what our topic was. Okay, so that was just basically random data collection. This is what I'm talking about. If you start randomly collecting your data, you don't know what to do with it. It just stays in your laptop, all forgotten, and you just regret the 1.5 years that was wasted in collecting the data. If it only was planned, it would have gone so much, better. Okay, so there is a sampling theory. How do you, select a sample, and how do you, make the sampling very efficient? It's basically the avoidance of bias, and then the precision of the given outlay of resources. So basically what you do is you look at your resources, and then you decide your sample size. If you only have, a limited amount of cash, a limited amount of time, you need to have a smaller sample size. It's always nice to have a large sample size, but if you cannot have a large sample size, it's okay to have a smaller sample size. You can always, magnify it with the SPSS software. So that was just a preparation. Now we move on to writing a research proposal. So just read these 2 or 3 slides. Okay. Yes, you can use that research for your CV, but you need to confirm that you do have your name in it. If you're from Pakistan, most of the times you do not have your name in it. You will be listed as a contributor and not an author. Yeah, if you're from Pakistan, again, you're going to be listed as a contributor. I don't think you're going to be listed as an author. If you are listed as an author, yes, you can do that. And you can also share that as a research contributing experience. If not a research article, you're not going to be an author. That doesn't really matter. You worked on it, and you guys had it published. Yes, yes, you can mention it in your CV. It's perfectly fine to mention that in your CV, and the GMC appreciates that, and the NHS appreciates that you've had some form of research exposure in your student life. Okay. So what does a research proposal do? What you do is you need to get your approval from the ethics committee. So ethics committee is going to be comprised of a few of the board of governors. It's going to be comprised of the psychiatry departments. There's going to be a lot of professors. So what you do is you make a summarized form of your research. What you do is you start from the top. What is the topic of your research? Why are you going to conduct this research? And now that you're going to conduct this research, what's the method going to be? What's the study design going to be? What's the sample size going to be? What's the time frame going to be? And how how you think this would affect the medical community in general. Okay, so there's always a summarized form of the research. You can always contact me on Telegram. I can share my own personal summarized form of the researches that I've presented over the years, and maybe you can have an idea if someone's stuck on that part. So moving on. That's again what I've already said, what you're proposing to do, how you plan to proceed, why you selected the proposed strategy, and why not any other else. Obviously, it's going to be the same question again and again. Why this study design? Why not any other study design? The answer is simple, because it suits you, and it suits the situation, and it suits the the generalized environment or your local environment, or it helps with data collection in your own culture. So these are the headings that you need to have. There should be a statement of the objectives of the study. There should be a list of hypotheses if you're testing any. If not, do not start forming random hypotheses. So the study design you're proposing to use and why you're using it. The setting for your study. What's going to be the setting? Is it going to be localized? Is it going to be, spanned over different cities? Is it going to be spanned over multiple countries? There are no limits when it comes to research. And what are the research instruments you're planning to use? The research instruments, as we've already mentioned, they can be pamphlets, audio recordings, video recordings, whatever you want it to be. Okay, so I'm just gonna open the chat and answer a few questions. So Birat is asking, does certain research design hold more value for PLAB than other designs? For example, is meta-analysis more value than a case report? It's not just about PLAB. Okay, you need to start at the bottom. Okay, so I'm just gonna list it out for you. Okay, I'll share this on the Telegram group. If you're on the Telegram group, that's gonna be perfectly fine. So the lowest form, research is a form of literature. Okay, it's a form of clinical literature. So the lowest form of clinical literature is a case report. So if you do not know anything about researches or study designs or complicated stuff, you can always start with a case report. Write your own case report. Find a case that has a peculiar presentation, an atypical presentation, okay, and just write something on it. Just have a look at some of the case reports that have already been written. There are online journals like Curious. There are also online journals like Lancet, the Journal of American Medical Association, just to name a few. These are very reputed journals. Okay, so what you should do is you need to look for your particular set of data. Okay, and once you've read through all of those, it's going to take a lot of time on your laptop. Trust me, it ruins your eyes. So once you've done that, once you've really found out how to write a case report, then you write your own. You learn from your mistakes, and then you move up the ladder. You write a case report, and then you move up. You write a literature review, then you move up. You write a systemic review, then you move up. You write a meta-analysis. Okay. Value-wise, as far as the NHS is concerned, as far as the GMC is concerned, you just need to be involved in a few research projects. If you have a few research projects as an author, that's a plus point. If you do not, you should at least be involved in some capacity as a contributing author, as a data analyst, anything at all. Okay. So yes, the meta-analysis is more valuable than a case report, and a proper original research article is obviously more valuable than a meta-analysis. Okay, but as an FY2, if you're going to give your PLAB-2, most of you are going to start as an FY2, and FY2 isn't really expected to have that much research background. Okay, it's nice to have it. Uh, most of my friends, they found a job even when they didn't have any research experience. Okay, but now when they're about to start training, they're working on that. Okay, now they're conducting researches. So researches are very important for training. It's not important to get an FY2 job. Okay, so moving on. Now you've formulated everything and then you collect the data. Once you've collected, there are certain methods, we've already discussed about the methods of data collection. Now imagine that you've collected all the data. Now you're going to analyze it. Okay, so yeah, there is quantitative, qualitative, attitudinal. Basically, it's the type of information you have. For example, if it's a descriptive report, okay, you're just going to describe the data. You don't need to analyze it. You don't need to quantify it. But if it's a quantitative or a qualitative, phase of data, you need to just run it through the SPSS software sometime, or you can do it manually as well. As our friend from Pakistan mentioned about his community medicine research project, I don't think they run it through the SPSS. Mine didn't. And what we did was we manually, analyze the data and we just put it forward for publication. Okay. So it's the same thing again. If it's descriptive, you just write it down. If you have a quantitative analysis, you need to then stress upon the type of the analysis required. Whether you want to divide your data frequency wise, whether you, analyze one single variable, whether you want to analyze a few different variables. Okay. So it's basically, I'm going to make it simple. It's basically you're looking at a child. Okay, he's 10 years old. He's a male. So variability is basically you want to look at it from a male perspective. He's a male. Done. That's your data. Okay, now I want to add more variables. He's a male. He's 13 years old. Okay, that's two variables. He's a male. He's 13-year-old. He has, his height is this. His height is 3 feet 6 inches. He weighs this many pounds. Okay, so these are tons of variables. Just like this particular example, you will have a lot of variables in your data. Be warned that the more variables you add, you include in your data, the more difficult it's going to be explaining it. Okay, so have it explained from your supervisor, take help of your seniors if you're actually going to attempt to do it. Otherwise, start small, then move on to the bigger and better things. Okay, then is the writing part. I personally hate this part. I'm a lazy person. I don't like writing stuff. Okay, I just like reading stuff. Okay, so what happens is you write an article. It has a lot of headings. It has an abstract. It has a description, and then you go on to discuss the data. Then you discuss the results, and then you present the results in the form of tables, different Venn diagrams. Okay, you will learn it as you move up the ladder. Again, for people, my advice is for people who have not had any research experience, go for a case report, write down a case report, get it published. If not, go for an audit. Audits are also appreciated in the GMC. Any form of research work, an audit, a case report, original articles are by far the best thing. If you can't do that, they're very difficult to come by. You can go for meta-analysis, you can go for systemic reviews. I mean, there are so many possibilities. You can become a member of any of the journals for free and become a reviewer. Okay, so what you do is you review the article, you find out grammatical mistakes in it, you find out some clinical mistakes in it. Okay, you find out some, anything you can find basically as a correction, and you are listed as a peer reviewer. So now you are a reviewer for a journal. Okay, so that counts as well. If you can't do anything, you don't want to do research right now, just go on, read some articles, find some mistakes. I mean, we're all good at finding mistakes. Okay, do that and it'll pay. Okay, so sorry about that. So that was some things about research. Okay, so now we're going to move on to the CV part. I hope everyone can see this. Okay. So I'm just going to share something new. Okay. Yeah, names for the journals. Okay, Dr. Heba. The names for journals are Journal of the American Medical Association. You can go for Curious. I'm just going to write it down. Cureus. Sorry. I'm just going to type it in the chat box. Cureus. So this is an online journal. You can go there. You can become a peer reviewer. Okay. Any journal, basically. If you're from Pakistan, you can go for the JPMA, Journal of Pakistan Medical Association. If you're from the UK and you want to have a good look at what good research projects are, there is always the Journal of New England, the New England Journal of Medicine. I'm just going to type this. I'm sorry if this has grammatical mistakes. Don't judge me. Okay, so these are just a few journals, and the topmost, obviously, where you can find the researches of Nobel Prize laureates. So that is the Lancet. Lancet is the most prestigious journal I have ever seen. It's one of my favorite journals, and I would love to get, my research or my article published in there someday. Anyways, so that was all about research. If you guys have any other questions about research, please, you can just type it in. I'm just going to give you a minute. If anyone has any questions, just type in the chat box, please. Okay. So I hope I've given you just a little, rough idea on what exactly a research is. Now we're going to move on to the CV part. The CV part is going to be easy. You've passed your PLAB-2. Everyone's happy. Once again, clap for yourselves. You passed it. Now all you want to do is, get a job. How do you get a job? You write a CV. How do you write a CV? You log on to the NHS jobs and you make your own profile. And trust me that, just making that profile. Yeah, the research part. Yeah, you can log on to different journals and become a member. There are free journals. Okay, so one of the examples I've written previously, it's called Curious, Cureus. Just like that, there are going to be a multitude or magnitude of online journals that you can find online. You can log on to them, make an ID for free, and then you can it'll start offering you whether you want to review articles or not. Okay, so you click on the review articles and it's going to present you with certain articles that many users have uploaded, okay, for publication. So what the journal does is it picks up its online members and it allows them to review the articles grammatically, clinically, or otherwise, or information wise. So you can become a reviewer as well. Okay, so that will also add to your CV. Anything you basically do is, it just adds to your CV. Okay, so coming to the CV part. Okay, coming to the CV. Yes, the word is Latin. It just means the course of life, just as formalities. Okay, yeah, one thing. A CV is more detailed than a resume. Okay, so imagine you pass your PLAB-2 and what you want to do is, start, you're making your profile at the NHS jobs, sorry. So making that particular profile is going to be a very difficult task because it's just complicated. You don't know what to write. Okay, so what normally people in Pakistan, they're very friendly. And what we do is we share each other's profiles. What we do is we take tips from each other. So when I started to make my own profile, I made this very clumsy version of my profile and I just uploaded it to the GMC and I started applying for jobs. So I wasn't getting any interviews even after like 2-3 months. And I was very tense. So I just asked one of my friends who was working in the UK at that time to just have a look at my profile. I gave him my ID and pass and he logged in, he logged on, and 5 minutes later he calls me and he says, what is this rubbish? And obviously I was surprised. That's my CV, I said. So he goes on like there's a certain way you present your CV. That's not how you present your CV. That's not how you make your profile. You haven't written anything that supports your clinical experience, and you haven't written any details about what you've done in your, internship rotations or, working as a medical officer afterwards, after graduation. So thank God, he helped me in creating my profile. And after that, within the next 15-20 days, I got 2 interviews. So a good CV, a good presentation is always going to come in handy. Okay, doesn't matter how many researches you have, doesn't matter how much experience you have. If you cannot put it down on paper, if you don't know how to write about it on paper, they're simply not going to consider you. Okay, because when you're applying online from overseas via NHS jobs, the only thing they know about you is from your CV, is from your NHS profile. Okay, so you need to make a good impression. You need to make them realize that they want you. Okay, so what does a good CV do? If you're applying privately, so these are basically general suggestions for a generalized CV. I'm going to talk about NHS profiles in like 2-3 minutes. So in a general CV, these are certain points that you might just take a screenshot of this, or just write them down or whatever. You need to know these points. You need to just implement them. That just looks good on paper. Okay, so don't post your pictures on your CV, people. That's not good. Trust me. CVs with pictures, I personally run away from. So it should be clear, it should be concise, it should be complete. By complete, they mean, for example, I have worked in neurosurgery. Okay, it's either I'm going to write down a line, I worked in neurosurgery. What have you done in neurosurgery? Obviously, I need to write down what exactly was my job in the neurosurgery ward. I wasn't a surgeon, obviously. I'm a junior doctor. I cannot be a surgeon. I haven't had my specialist degree. So what I did was I helped the consultant. I assisted him in different surgeries. I learned about instrument use. I learned about the manners of working inside an operation theater. I looked at emergency neurology cases, neurosurgery cases. I learned about extradural hematomas. I learned about subdural hematomas. I looked after patients in the indoor wards. I looked at the patients in the outdoor wards. I was specially, allowed to visit my consultant's clinic in the evenings, where I had the privilege of working with him, where I started to grasp some, vital information about how to manage, how to diagnose, take histories of, and manage many neurosurgical diseases like sciatica, like nerve damages, like chronic conditions like epilepsies, stuff like that. Okay, you just need to make it very clear, very detailed, and apply this to your NHS jobs profiles as well. Okay, they will want you to do it. They want to know what you know. Okay, it needs to be consistent. It needs to be up to date. So if you've done anything new, you need to update that CV. You need to keep that updated. Otherwise, they're gonna miss it. Because once again, the only thing they know about you is from your CV, is from your NHS jobs profiles. And if that's not updated, well, the story's over. So that's just some general, things I collected, I learned basically. So content should be a summary of skills, experience, and education. What's going to be the purpose of your CV? It's obviously to get a job as far as the NHS is concerned. It can be, you can also you can also make a CV to apply for observerships. Okay, people do that. They require a CV for you to do that. So you need to let them know what you know. Okay. So what's in a CV? It should have publications. If you have any presentations or awards and any honors or affiliations, I have not had any. So those of you who have, congratulations, just add them to your CV and yeah, never look at me again. So this was just a general gist about your CV. So now I'm going to talk about the NHS profiles very quickly. So once you log on to the NHS profiles, they're going to be on the left-hand side of your screen. There are going to be very few headings. The first one is going to be about your personal information, where there's your name, your visas, all of your details, information stuff. Then there's going to be your, the most important part in that left-hand corner would be the supporting information and the procedures you've done. So what GMC wants to know is how many procedures do you know? Okay, only write the procedures you guys have done, and do not write the procedures that you think will impress your trust or the interviewers, because once you're there, they expect that you know that stuff. Okay, so no lies in your CV, people. If you do not know how to perform a lumbar puncture, just say I do not know how to perform a lumbar puncture. It's perfectly fine. They are not judging you for that. Okay, so many of you who are from Pakistan, who have done your internship from Pakistan, you have basically done everything there is to be done in your internships. You've done your lumbar punctures, you've done your endotracheal tube insertions, you've done your CVP line insertions, you've done your generalized surgical procedures, you've done an appendectomy, and you've done your hernias, and you've done your all that complicated stuff. So don't go on and mentioning everything in your CV. People from Africa and people from Pakistan. Okay, you guys do a lot of hard work here. Uh, Nobody is denying that, but you do not go on and say I have performed independent hernia surgeries or I have performed independent appendectomies. They're not going to appreciate that. Okay, just stick with the simple procedures, stick with endotracheal intubations, stick with the CVP lines, stick with the nasogastric intubation, stick with IV lines. Okay, and then comes the supporting information, which is going to basically decide why do they want to hire you. Write down all of your qualities in it. Why should they hire you? A great way to prepare your NHS jobs profiles is 2 or 3 blogs. There was this old blog called Nasir's Journey. So there was a guy, Nasir. He basically wrote all of his his whole journey of PLAB and getting his observerships and how to create an NHS profile. So it's basically a step-by-step guide with screenshots, so you can follow that. Or there is another page, there is another blog. It's called Omar's Journey, OMAR, Omar's Journey. So these two are there are 2 blogs. I'm just gonna write them down in the chat box for people who do not know. Blog and Nasir's Journey is very famous. I doubt if anyone doesn't know him. Okay, so these are the 2, Umar's and Nasir's. So you can go on and have a look at their blogs, and you can go on and have a look at how their journey went, how they prepared for their own PLAB exams, what difficulties they encountered in the UK. Basically, they shared every single one of their experiences. Okay, I hope that covers your CV and your research. I focus on research a lot. So now we are going to focus just a little bit on the sorry, there's a question. Yes, I've written them down. It's Omar's blog and Nasir's journey. Okay, you can follow the chat. I've written them down already. Okay, so now we come on to the small stations and the unrevealed stations. Now this is going to be fun. Now, so previously all of this was very boring as far as students are concerned. So now we come to the fun part. So imagine there is a new case. Yeah, imagine you're giving your PLAB-2 exam. It's 8 a.m. sharp. You're at the Hardman Square. You have your cup of coffee in your hand. You have your biscuits or whatever you want to eat. You have your bananas in your hand. So you enter and you start your exam. You have your check-in. Now you're inside. You're very confident. You're well prepared. And all you want to do is, just get the exam over with, pass it, and just move on with your lives. So you stand in front of the room, the clock rings, the station starts. And you start reading what's written on the wall. So you read it, and then you feel like this is a new station. and then you panic, and then you lose all sense of time and space, and then you start existing in another dimension where you pretend that you were not here. That actually happened with me. So there was a case when I was appearing for my exam. So this was a 32-year-old female who came to the GP practice, and the only statement that was written was she has some concerns, and my objective was address her concerns and manage accordingly. I was confused. Okay, fine. There is a patient inside, and I don't know anything about it. So that's great. So I went inside, and there were two people. One was sitting on a bench, and one was standing alongside. And there was the examiner on the right-hand side of the room. He was a very serious man. I was not. Anyways, so once I entered the station, the person who was standing in front of me, he was basically the male nurse. It took me around 30 seconds to 1 minute to figure out what exactly was going on inside that station. So I go inside, and the person standing, who was the male nurse, he just takes two very quick steps. I wouldn't call them steps, honestly. I would call them lunges. Anyways, he took two quick steps towards me, and he started with the sentence, doctor, there's been an emergency. That was my third station of the exam, by the way. I was very confused. I was very scared. Also, I hadn't had breakfast. I had low blood sugar. So I panicked, and I was like, what's wrong? What's wrong? And then he looks at me funny, and then he says, we have a patient with a history of a fall, but I don't see anything wrong with him. So I don't know what to do with him. I'm basically an FY1, and I'm very confused. And then my only response was basically inside my brain. And what I said to him inside my brain, obviously I didn't say it out loud. It was, brother, I'm more confused than you are at the moment. Trust me. I expected a very easy station at this point. Anyways, this PLAB-2 exam is not going the way I wanted it to. So I introduced myself to him. I'm like, do you know me? He's like, yeah, no, I don't know you. I just saw your lab coat, and then I just saw the stethoscope, and I just came in. And then I introduced myself to him. So, hi, my name is Dr. Daniel. I'm one of the junior doctors. I'm an FY2, and you are? He says, my name is Sam. I'm an FY1. I just started my rotation here. It's my second day, and I'm very confused. I just received this patient. So basically, what that station was, the person was walking in the park, and she just fell. And then she lost consciousness. And then she regained consciousness and was brought to the hospital by her husband, because her husband was worried. Okay. So up till now, by that time, it had been 2 or 3 minutes, and I started talking to the patient. I had wasted a lot of time in that station. No wonder I failed that station. Anyways, so I started talking to the patient, like, hi, my name is Dr. Daniel. May I confirm your name, please? And then she was like, my name is this. Okay, so would you like to tell me what happened? Yes, doctor, I was walking alongside my husband. We were just taking a stroll in the park, and I think I just tripped on something and I just fell. Okay, so did you feel, and then I just took the standard history that Dr. Farwa just told you. I was basically ruling out epilepsy. I was basically ruling out hemorrhages. I was ruling out anything that I could brain-wise. Okay, anything that could make her fall, from epilepsy to low blood sugar. Every single thing. I asked that woman every question in the book. I spent 2 or 3 minutes asking her questions, and it was a very quick, back and forth. Okay, so have you had any of these episodes before? No, doctor. Okay, so has this happened? So this is the first time it happened. Yes, doctor, this is the first time it happened. Okay, and how did you feel before the fall? Did you, would you like to tell me how you felt just before you fell? No, doctor, I just tripped over something. Okay, and while you were falling, did you have any thoughts in your mind? No, doctor, I didn't have any thoughts in my mind. Okay, so once you fell, you lost your consciousness. Yes, doctor, I think I did. Okay, and do you remember anything immediately before losing your consciousness? No, doctor, I don't remember it. Okay, and just like that, my whole history was over within 3 minutes. and I did not have a diagnosis. And I was confused, very confused over what to do with this case. So the bell rings, it's management time, it's 6 minutes have gone by. I haven't done anything in the station besides taking a very clumsy, a very shady sort of history. And I don't have any information. Maybe I wasn't getting the clues in. Maybe there were some, non-verbal cues that I was, uh, missing. So I started so then I just did the unthinkable. I just asked if I could examine her neurological systems. So what I did was I started with the Romberg test. I started with basically think of an exam. Think of any neurological exam. I tried to just, cram it all within 2 minutes. I could just only get like the decidokinesia test. I did the Romberg test. I did the modified Romberg test. I made her walk on a line. I made her jump. I did the sciatica thing. I did the straight leg raising, and she was very patient. She was very patient. Either she was very patient, or the other explanation is she was very stubborn, or maybe she was enjoying. Anyways, so after everything that was done at the neuro examination, everything was normal. So then she asked the one volatile question, which I did not expect. So, doctor, can I go home now? And I was shocked. 30 seconds on the clock, and I think 30 seconds to 1 minute on the clock. And I said, yeah, sure. I see no abnormalities, and yeah, in my opinion, yeah, you can go home now. So basically, I'm an FY2 who is discharging patients now without his consultant's approval. So when the results came out, I had 4 marks. I had 3 marks in interpersonal skills, and I had, I think, 2 marks in history taking. They gave me a 0 in management. So then I asked around. So basically, after receiving the results, I had already passed my PLAB-2. I asked around, and all of my friends who were very good doctors, they suggested that you should have kept her under observation for at least 6 hours or 4 hours, 4 to 6 hours under observation. And then I asked the one major question: why would I keep her under observation? I did the examinations, I did everything that was to be done, and I took the history. There was nothing wrong with her. They said that there could be something wrong, and there could be a subdural hematoma. You should have had her investigated. You should have had had a consultant opinion. You should have reassured her that there was nothing wrong with her right now, but you were going to investigate further. Okay, so when you're inside the exam, it's a very different environment from when you're practicing. So if a new station comes into your exam, it's very crucial that you know how to deal with those cases. Okay, I was prepared for the 287 cases or the 326, I don't exactly remember the station count, that I had already prepared. I was well versed in those stations. I was very good with those stations. I trusted my interpersonal skills. I had very good IPS. I am very good with ICE even now. I have made it a part of my life even now to talk to the patients in the GMC way, even in Pakistan. So good IPS does take you a long way, but sometimes you just need to think on your feet. Okay, so I'm just going to discuss this one more case. So I had 2 new cases in my original GMC exam, by the way. I am amazed that I passed. Anyways, so this next case was very interesting. There was a woman, and she had been admitted into the hospital for rectal bleeding before. So once I went inside the station, the woman basically I started talking to her. It was a very natural station. Like, hi, my name is Dr. Daniel. I introduced myself. She introduced herself. We started talking. So this was basically GP surgery. She had been previously admitted to the hospital and was discharged from there. She was declared okay and fit, and now she had come to the GP with some concerns. So I started to take history. Why were you admitted in the hospital? And she told me that, doctor, there was blood coming out of my stools. There was blood coming alongside my stools, sorry. And I said, okay, how often did it happen? And doctor, it happened only once. And then I was shocked again. Okay, so it happened only once. Yeah. So what did you do? Doctor, I went to the emergency department. Okay, and what did they tell you? Yeah, they told me to come to the outpatient department and get it checked. And they basically reassured me it was nothing. It might be a case of hemorrhoids or it might be a case of anal fissure. So they explained the conditions to me and then I came back. Okay, that's great. So then her history was basically she went back to the hospital. They had her admitted, and they first started with the proctoscopy, and then the sigmoidoscopy. They couldn't find the lesion, and then they did the colonoscopy, and then they also did the endoscopy. So basically, they looked all through her intestines. They couldn't find anything. So that was just one time occurrence of the blood, and now she came back, and then I asked her, "What are your concerns right now? What are your complaints right now, basically?" And she told me, "Doctor, there's blood coming with my stools again." I just looked at her with pleading eyes. "Don't do this to me," I said in my heart. And well, I said, "Okay, and how long has this been going on for?" She said, "Doctor, it just happened one time yesterday." I was so angry at that woman. Anyways, so I couldn't really crack the case, but I think I don't remember if I passed or failed that station. I think I passed in on margin. Anyways, so once I came back, we discussed all the stations. The academies. They just they have their review feedbacks, like what were the stations you had in your exam. So I received a call from my one of my teachers, and he asked me about these stations. He said, "Did you receive those stations?" Like, yeah. "What did she tell you?" I said, "She told me nothing." He said, "Yeah, she never told anyone anything. We do not know what to do with that station. We don't have approach for that." Anyways, we now have an approach for that. It took them, I think, first of all, that station was rejected. What GMC does is if they want to introduce a new station, they will introduce that new station. But if a lot of the student population, they do bad on that particular station, they reject the station. Okay, so basically, if you have 18 stations and two of them were new stations, and out of those two new stations, one of those stations the students performed very poorly, so they just deemed that the station was too hard. Okay, that the majority of the students, they failed the station, so the station was basically too hard, so they would just cut that station off. They would reduce the passing percentage and they would make it 17 stations. Okay, so there are going to be scenarios. What basically I'm trying to tell you that there might be newfound scenarios. There might be tester stations. That's what we call them. I don't know what GMC calls them, but there might be tester stations, and they're nothing to be afraid of. What you need to do when that happens is you just ask the patient. You can ask them for a minute. Okay, it's your time. Obviously, they don't care. So if you're very confused, if you're very, for a lack of better word, traumatized by the new station, you can ask them for a minute. Okay, could you excuse me for a moment, please? Just ask the patient for some time. Could you excuse me for a moment, please? And then you take your 5, 10, 15 seconds, get your bearings together, think about what you're going to do in those 5, 10, 15 seconds, and then you start it again. Okay, it's allowed. I did that with the woman with the occult bleeding. I took my 15 seconds. I asked her, "Could you excuse me for a moment? I'm not feeling well." And then she said, "Okay, no problem at all." And then I took like 5, 10 seconds. I took a few deep breaths, and then I started. And then I looked at her, picked my head up again. I looked at her, and then I said, "Okay, we can move forward now." She said, "Are you okay?" I'm like, "Yes, I'm okay now. Thank you very much for asking." Okay, it's just that easy. Just treat the GMC exam like any day at the clinic. Please treat it like any day at the clinic. Don't stop treating it like an exam. They're not just looking for knowledgeable doctors. They have knowledgeable doctors from Cambridge. Okay, they have those. What they're looking for is the best version of yourself that you can put forward when you're taking care of the patients. Okay, so do you guys have any questions now on researches, on CV buildings, and on this very sad and yet funny story that I just told you. Any questions, please? Either I'm very good at explaining, or you people don't know the questions. Okay, any questions, please? No questions? Can I get a yes or a no, please? Thank you. Thank you for saying no. You guys ask very hard questions. Okay. Thank you very much. And if you have any questions at all, you can always, text our groups at Telegram. If you wanted to revisit any of our webinars, you can go onto the website as well. You can go onto YouTube as well. Okay. Thank you so much, Dr. Jamila. And I hope this is it. So I'll just hand it over to my superiors and my coworkers. I don't know where they are. Let me find them. So yeah, this is it. If you guys, how many cases are presented in the exam? How many of the tester cases, or how many of the cases in general? I gave the exam in 2019. Okay, in general. Okay. Basically, there's a list of cases. Okay, when you're preparing for PLAB-2 exams, the cases, they keep on rising overall. So when I gave the exam, we had 326 stations to practice on. Right now, I think the count is on 382 or something, around about that, 360 or 380. So these 360 or 380 are the old cases from, yeah, that is quite a lot. Yes, that is quite a lot. CV good to be submitted to the NHS. Yes, I can. What I can do is, I will try and share my own NHS profile copy to the Instagram. Oh, not Instagram. Sorry. To the Telegram group. Sorry. I haven't slept for days now. Sorry. I work in surgery. Yeah, in the Telegram. I don't have a WhatsApp group. I can share that in Telegram as well, or I can give it to the med exam administration and they can share that with you. Okay. So yeah, and talking about the stations, I'm sorry, I just forgot. So that's like 370, 360, 380 stations. So on an average, I would suggest you take around 30 to 32 days for preparing your exam. Okay, after you're done with the academy, it's sometimes the academies are 15 days, some of the academies are 14 days, some of the academies will be 1 month. So once you're done with studying, because you don't get time to study in your academy. Okay, so you're there from 8 a.m. sometimes 10 a.m. to 4, 5, 6, 7 p.m. sometimes, and you're studying consecutively. You just get saturated. So once you get home, I would suggest that just eat your dinner, try and sleep as much as you can. And once the academy is over, you can read whatever you've written down, or whatever the material the academy provides you with. You can read that in those 15, 20, 30 days. Afterwards, you take 30 days. Yes, it's the course. Yeah, here in Pakistan, we call it the academy. We're very third world. Yeah, it's the course. I'm talking about the course. I keep forgetting there are people from outside Pakistan. Sorry. So yeah, it's the course. So once you're done with your course, no, you don't have to take it before every exam. It's not compulsory. It's just a choice. Okay, a course is a choice, because most of the foreigners like me and like many other people, we're not, we're not used to how the NHS works. No problem at all. Okay, so you're from Algeria, see, and I'm from Pakistan. Both of us, we do not know how the NHS works from the inside. So just to get a know-how of the system, of how the patient care works, we need to, get these courses. That's why basically these courses are. That's the reason for these courses to exist. because we do not know how the system works in the UK. Our systems are very different from those of the UK. So taking the courses in that. They're called courses in the UK. Yeah, they're called courses in the UK. Don't worry about what they're called. Just take them and pass your exam and start working in the UK. That's more important. Okay, so I would suggest after your course is done, you take 28 to 30 days, maybe sometimes 32 days. I personally took 35 days after my course was completed. And then I practiced each and every single station. And I tried to practice every station twice. So there were like 326, 27 stations. I still have the list, I think, somewhere. So find your practice partners and start your practicing. Try and practice, not online, but in front of each other. It's always preferable to have your partner in front of you instead of having a live session. That way they can assess your body language, and that way they can always, point out what deficiencies you have in your non-verbal cues. Work on your facial expressions. If you don't have a partner, just find a very big mirror. If you can't find a very big mirror, just buy a mirror. It varies from person to person, Dr. Hiba. I took 35 days. One of my friends, he took 26 days. Another one of my friends, he took 15 days to take the exam, and all of us passed. So it just depends on basically your level of satisfaction. Yes, do obviously practice every case with a partner. It's necessary. I wouldn't recommend it. I would say just do it. It's necessary. Okay. No, it's not required to take up mocks from the recognized academies. You can do this without mocks. Mocks are just there to help you assess your own preparation. The same can be done by your research partner. You keep 2 or 3 research partners. Sorry, I haven't slept. Not research, practice partners. Personally, the method I employed, I'm just going to tell you my own personal experience. We were 4 friends, okay, and 2 of them were practicing with each other, and me and my one other friend were practicing with each other, okay. So what we used to do was we did 5 cases each group, and then we shuffled groups. Okay, we shuffle groups because once you practice long enough with a single person, you start to know their verbal and non-verbal cues. So just to mix things up, we used to switch partners. And after we did the whole course one time, after we practiced it one time, I took 3 days to read the whole thing once more on my own. And then we made these very nice Egyptian friends and very nice African friends. And I started to practice with them as well. Okay, on and off, just practice on and off. Just one station with this guy, one station with another guy. That just made me comfortable with different accents. And that just also made me personally comfortable that I can deal with any new thing put in front of me. It's really easy. No prior clinical experience. I mean, you're just out of house. You're just out of house job. I'm just gonna assume you're from Pakistan. So if you're in last year medicine and you're about to do your internship, your internship is going to be enough clinical experience for you. Okay. GMC is passing an exam is not that hard. I mean, it takes 30, 35 days. Passing the exam is not hard. You just work on it very sincerely and you're going to pass the exam. Okay. It's not that hard. GMC makes it very easy for you overall. I passed in my first attempt. I'm a very average student. Okay. All of my friends who passed were very average students. Okay. We were amazed we passed the medicine and then we passed PLAB. Okay. So don't be demoralized if you do not have clinical experience. Your clinical experience was PLAB-1 is definitely harder. PLAB-1 is definitely harder. Honestly, you need to sit around and study. PLAB-2 is just fun. PLAB-2 is just so much fun to prepare. You're sitting with your friends, you're doing 2 or 3 cases, and then someone says something funny and then you laugh. Okay, PLAB-2 is just so much fun. simply. Okay, so during an exam, some cases of management, the patient should discuss with the senior. Okay, so I talked about this in the last webinar I had involving seniors. Okay, if you cannot establish a diagnosis, just give her certain differential diagnosis. Okay, don't just go on and involve the senior. Your seniors are very busy. Okay, so what I would like you to do is, for example, there is a case where you're suspecting either a subdural hematoma. For example, there is a patient coming in with fits. Okay, so you're considering epilepsy, and then you're considering a subarachnoid hemorrhage as well, because she was unconscious as well for like 2-3 minutes before the epilepsy, and then she started having fits afterwards. So the first episode was only unconsciousness, and the second episode was fits. Okay, so that's the scenario you're presented with. So now you're confused between epilepsy and subarachnoid hemorrhage, and you're very confused. You can't, go on with the diagnosis. You can't tell the patient. So what you do is you take the approach. You do not just involve the seniors. Seniors are very busy. Again, don't involve the seniors until and unless it is absolutely necessary. So, okay. So let's call her Mrs. Johnson. Okay, Mrs. Johnson. So after listening to what after listening to what you've told me, and after my examinations, I have come up with a few possible things that might be wrong here. There is something we call a subarachnoid hemorrhage. Are you listening? Or are you getting me? Okay, good. May I explain what subarachnoid hemorrhage is? Okay, it's a bleed in the brain, a minor blood vessel that just pops, and sometimes it may cause unconsciousness in a patient. Okay, and it's not that dangerous in most of the cases, but just to rule it out, we're going to have some investigations done. Another possibility that I was looking for was it might be a case of epilepsy. Do you know what epilepsy is? Like, no, doctor. Okay, so epilepsy is when the neurons or the cells in your brain, they start firing abnormally, and then you can experience these fits. Okay, so the things that I have told you, both of these things, the subarachnoid hemorrhage and the epilepsy, both can be diagnosed with a CT scan of the brain. So what we're going to do is we're going to get a CT scan of your brain, and we're going to send in some blood works. I would like to take a sample from your back. That's what we call a lumbar puncture, and we'll also get a CT scan to rule out anything that might be causing this. Okay, and once we've had something concrete, once we're done with the investigations, once we have the results, we will definitely let you know what's exactly causing the symptoms. Okay, and that's how you approach this. You don't involve seniors. I mean, do you involve seniors here? I don't think you do. Okay, so even if his IPS is very good, the management was flawed. You might pass on margin, but I would say don't involve seniors. It's just not appreciated. Everyone just starts involving seniors. Any suggestions on how to prepare for PLAB-1? Yes. Attend our med exam courses. No, just do attend our med exam courses. Anyways, how you prepare for PLAB-1 is you take your final year subjects and your fourth year subjects. You take your eye ophthalmology and ENT, and one of the two books. There are certain things called PLAB keys. They're very famous right now for some reason. There is also PLABable. Okay, there is a question bank that the med exam people have prepared for you. You can do different question banks, read the explanations of the MCQs, just get your knowledge in. I would say instead of reading a book and being a bookworm, just go for the MCQ straight ahead. Okay. How much time on average does it take to secure a job after passing your PLAB-2 exam? It can take around 2 or 3 months sometimes. Okay. Because I ruined my CV, as I've told you before, I really just botched my CV to the worst degree. And it took me around, and it was COVID. Obviously, I was back at my home, and it took me around a year, and that was a very long time. Normally, that was due to COVID-19, obviously. Okay, there were restrictions in place. The UK people were not really keen on hiring foreigners and all that stuff. And also, I wasn't applying for that much jobs, if I'm being honest. I'm a lazy person. So it takes around 2 or 3 months. No, you cannot pass your PLAB-2 with just good IPS. You need to have a working knowledge of the stations and the working knowledge of the conditions you're treating. You need to have good management skills and good history taking as well. Because remember, the IPS it's just 4 marks. Okay, so the rest of the marks are 8 marks are for the history taking and the management as well. So you need to focus on that as well. Okay, so do you have any other questions? You apply for the NHS. NHS is basically, I wouldn't say government or non-government. NHS is just a separate entity. It's working for the UK government, okay? And the private sector, it's called the NES. I'm just gonna write it down. It's the NHS and the NES. So NHS is basically, let's just call it the government forum, and the NES is the private forum. Okay, so you can apply for both. Okay, so yeah, you just no, they don't just take care of finding you a job. You are going to upload your CV. You're gonna have to make a whole detailed CV on the NHS jobs website, and there you're gonna have your daily emails coming in from what jobs are available. So whatever job suits you, you're going to apply for that particular job, and if they find you appropriate for that particular job, they're going to email you and approach you, and then the interviews can take place. Yeah, obviously. Angry patient and breaking the bad news, you already have the data in the breaking the bad news station. Okay, it's about how you break it to the patient. Okay, and then how do you manage the situation afterwards? If the patient is crying, you just don't hand her an imaginary tissue. Yeah, correct. Are the salaries any good? Yes, the salaries are very good. We are from third world countries. The salaries are very good. It's better than what they pay us here. No problem, Kala. No problem. So, any other questions? Yes, I will be sure to share my CV on Telegram. You're welcome, Dr. Ataul Mustafa Ahmed. Okay, so that was the session, guys. I hope you found it informative at the least, and happy to help. And hopefully, we in our next session we can cover more topics. Okay. Yes, we can send the link of the Telegram group. We'll just share it to everyone in this, everyone who's attended here. Thank you, Sayed Razi. I hope you get a job. I honestly hope you do. Anyways, so this was the session, and goodbye for now. Can anyone share? Yeah, they're gonna share it in the WhatsApp group and the Telegram group as well. Don't worry about it. All links will be shared in both the WhatsApp group and the Telegram group, and I'll make sure to put in a standardized form of the CV as well, so you guys can see what CV looks like. And I'll also go on and ask my friends if they can share their own CVs who are currently working in the UK. I'm not currently working in the UK, but they are. So if there's anything that you guys can gather from them and have help from that particular event, that's going to be fine with me too. Okay, but only if they agree. All right. Thank you, everyone. This has been a nice session. See you soon. Bye bye.